Hey there, curious minds and future healthcare heroes. Welcome to the deep dive. Today, we're cutting through the noise to explore a really critical area of nursing, intraoperative care. It's right at the heart of patient care. We're drawing our insights from Lewis's Medical Surgical Nursing, the 12th edition. Our mission, well, it's not just to summarize, but really to pull out the vital why and how behind safety and precision in the OR.
That's right. If you're navigating the, let's say, complexities of surgical environments, this deep dive is sort of your shortcut, not just to know the basics, but to really get the implications. We'll unpack everything: the physical environment, the surgical team, patient management, anesthesia, even those critical crisis events. What's really fascinating, I think, is how every single piece, from air quality to, the surgeon's incision, it all forms this sophisticated dance, all centered around the patient.
Okay, let's peel back the layers then. We'll help you connect the dots for your studies and definitely for your future practice. Make this dense stuff digestible, hopefully deeply insightful. First up, let's paint a picture of where this all happens, the surgical department. It's not just any space. It's a highly controlled ecosystem, meticulously designed to, well, minimize pathogen spread and keep things flowing smoothly and safely. When you step inside, you immediately notice these distinct zones.
Absolutely. And these zones, they aren't just lines on a floor plan. They're like a layered defense system. Think of it as escalating levels of sterility the closer you get to the patient. You start in the unrestricted zone. That's your entry point. Street clothes are fine there. It includes the pre-op holding area, locker rooms, the nursing station. It's sort of where the patient's or our journey begins.
Okay.
Then you move into the semi-restricted zone. This covers support areas, corridors. Here you absolutely need clean surgical attire: scrubs, long sleeve jacket, dedicated shoes or covers, head cover, maybe a face shield, PPE basically.
Nice, a clear visual cue.
Exactly. It signals you're entering a more controlled space. And finally, the restricted zone. This is the core. The OR itself, the sterile core where instruments are prepped. In this zone, masks are mandatory. Traffic is strictly minimized, especially when sterile supplies are open. It's the inner sanctum.
Wow.
And the physical layout itself is critical, keeping clean and sterile supplies totally separate from contaminated items. It's all about preventing cross-contamination. And it's no accident the OR is usually near the PICU, the post-anesthesia care unit, and the SICU, surgical ICU. That placement, it allows for quick transport if needed and immediate access to anesthesia staff.
It's incredible to think of the whole department as this, living system of protection. But of course, none of this happens without the team. It's not just a group. It's a precise choreography, right? Highly skilled experts.
Indeed. It's remarkable how these specialized individuals just mesh into a single seamless unit. Every role is indispensable. At the heart is the registered nurse, RN, the perioperative nurse. As the RN, you are the patient's advocate, period. Through the whole journey, pre-op, intra-op in the OR, and post-op in the PICU. As an ORRN, your responsibilities are huge. Maintaining safety, dignity, confidentiality, communicating clearly with everyone, providing that comprehensive nursing care.
And within the OR, the RN can wear different hats.
Exactly. Two distinct complementary roles. The scrub nurse handles sterile activities: surgical hand asepsis, gowning, gloving, preparing the sterile field, passing instruments, and critically keeping track of sponges, needles, instruments. Those counts are vital.
Okay.
Then there's the circulating nurse. They manage the unsterile activities, preparing the room, checking all the equipment, like making sure electrical devices are safe before the patient arrives, maintaining aseptic technique, connecting verifications, assessing the patient constantly, assisting with monitoring, documenting everything, coordinating, and finally facilitating transfer to PICU.
A lot of oversight there.
A huge amount. We also have LPNSVNs and surgical technologists playing key support roles, always under RN supervision. Then, of course, the surgeon and assistant. The surgeon leads, handles the pre-op assessment, informed consent, directs the procedure. The assistant helps expose the site, control bleeding, suture.
Got it.
And finally, the anesthesia care provider, ACP, the specialist administering anesthesia, managing vital functions. This could be an anesthesiologist, a CRNA, certified registered nurse anesthetist, or an anesthesiologist assistant, an AA. CRNAs, for example, do pre-anesthetic assessments, create anesthesia plans, give drugs, manage airways, oversee recovery. It's a highly specialized role ensuring patient safety and comfort.
That's an incredible level of teamwork. With so many critical roles, I imagine communication isn't just important, it's, well, everything. How do they synchronize in those high-pressure moments?
That's a really crucial point. It's a constant thread. Communication is key. But it actually starts even before the patient hits the OR suite. We've built this controlled environment, assembled this amazing team, but right at the center is the patient. So what are those steps we take to prepare them, not just medically, but emotionally too, before they even get there?
Exactly. This gets right into nursing management. What happens before they even touch the operating table?
Right. How do we make sure the patient is truly ready? As a nurse, your role in nursing management before surgery is pivotal. You're providing comfort, physical and emotional, especially for anxious patients or maybe same-day surgery patients who'll have more post-op responsibility. You'll answer questions, use interpreters if needed, sometimes let caregivers stay in the holding area to ease anxiety. A thorough physical assessment, reviewing their chart vitals, allergies, labs, helps catch potential issues, like infection or other complications.
Hmm.
Then, admitting the patient. This is about setting up a safety net right away. A warm greeting, multiple ID checks, reassessing them, checking valuables, prostheses, confirming last food fluid intake, making sure pre-op meds were given. You might even offer things like music or aromatherapy in holding. Little things to help reduce anxiety before they move into the OR itself.
So once that careful admission is done, the real deep dive into active intraoperative care begins. What are the first steps then? Preparing the room, getting the patient there safely.
Exactly. And care in the OR is incredibly dynamic. Constant vigilance. The circulating nurse especially is always assessing, always advocating. Room preparation happens before the patient even enters. Setting up for privacy, infection prevention, absolute safety. For instance, if you know you have a severely obese patient, you anticipate needing extra staff, maybe special equipment like a bariatric OR bed. Always. Everyone wears the right surgical attire, scrubs, head covers, shoes, all equipment gets checked thoroughly. And critically, before anything starts. Counting sponges, needles, instruments, strict protocols, because a retained item, that's a never event.
Yeah.
Devastating consequences.
Absolutely critical.
Then transferring the patient. Privacy is key. And
Yeah.
safety rule number 1, always lock the bed wheels during transfer. Use enough staff, use ergonomic tools, prevent injuries on both sides. Once they're on the OR bed, someone stays on each side until safety straps are secured. No falls. Then monitors go on immediately. ECG, BP cuff, pulse oximeter, continuous monitoring starts right away.
It's clear everything is geared towards prevention. And a core concept, obviously, is guarding against infection. How do we ensure that?
It boils down to rigorous aseptic technique. It's like this invisible shield against infection. For scrubbing, gowning, and gloving, all sterile team members, scrub nurse, surgeon, assistant do surgical hand antisepsis. Whether it's a wet scrub or an alcohol-based agent, the technique is precise. Clean nails first, then scrub every surface of fingers, palms, forearms, moving distal to proximal. Always keep hands away from scrubs and higher than elbows. After scrubbing, sterile gowns, and importantly, 2 pairs of gloves. That double gloving gives extra protection. The basic aseptic technique principles, they're non-negotiable. Like, if a sterile item touches an unsterile one, it's contaminated. Done. Only the front of the gown, chest to table level, and sleeves up to 2 inches above the elbow are sterile. And remember, microbes travel in airborne particles, even through wet fabric. Plus, adhering to OSHA and AORN guidelines for bloodborne pathogens, using standard precautions, PPE gloves, gowns, masks, that's essential too. The OR is high risk for exposure. Finally, preparing the surgical site. The prep. The goal is to reduce microorganisms near the incision, usually mechanical scrubbing with an antimicrobial agent, moving from the clean incision site outwards to dirtier areas. These agents, often alcohol-based, can be flammable. So you have to confine the solution, make sure it dries completely, prevent burns or fire. Once prepped, the sterile team drapes the area, leaving only the incision site exposed. It's a masterclass in controlling the environment.
It really is. So the sterile field is foundational. But patient safety goes beyond just preventing infection, right? It involves this whole web of communication, standardized protocols, protecting against different risks.
Precisely. It's about building in checks and balances, because in a high-stakes place like the OR, human factors are just as critical as technical skills. This is where non-technical skills, NTS, come in. Clear communication, teamwork, situational awareness, managing stress and fatigue. Communication is vital with so many people involved. To ensure good handoffs, the Joint Commission mandates standardized tools like SBR situation, background assessment, recommendation. Used, for instance, when the ORRN gives report to the PACURN, complete, accurate info transfer. We also rely heavily on the Surgical Care Improvement Project, SCIP, that national initiative focused on reducing complications. As a nurse, you'll implement key SCIP measures, like giving prophylactic antibiotics 30-60 minutes before incision, using warming blankets to prevent hypothermia. applying intermittent pneumatic compression devices, IPCs, to cut down VTE risk.
Standard practice is making a big difference.
Huge difference. And of course, the absolutely crucial timeout and surgical checklist. The National Patient Safety Goals mandate pre-procedure verification, make sure all docs, equipment, everything is ready. The universal protocol is followed strictly. Prevent wrong patient, wrong site, wrong surgery, another never event. The surgeon marks the site, involving the patient if possible, before the OR, and the WHO Surgical Safety Checklist. Proven to significantly improve compliance and reduce complications. We also always do a fire risk assessment, identify and mitigate those risks too.
It sounds like an incredibly robust system,
Well,
layers upon layers of safety. And once the procedure's finally wrapping up, what's the next critical step for the patient?
As the surgeon finishes, the ACP starts anticipating the end, carefully adjusting anesthetic agents for a smooth emergence. Then, the patient is transported to the PACU with a comprehensive handoff report. Status, procedure, details everything needed for safe, ongoing care. A seamless transition.
Okay, let's shift gears a bit. Let's talk about anesthesia. It really is a whole world of its own, ensuring comfort and safety during surgery.
It truly is an art and a science. The American Society of Anesthesiologists, the ASA, defines anesthesia by its effect on sensation and pain. Choosing the right technique, it's a collaboration. ACP, surgeon, patient. You consider the patient's status, age, allergies, pain history, the procedure itself, and patient refusal. That's an absolute contraindication, always. Patients also get an ASA physical status classification, ASA1 to ASA6. Higher numbers mean higher risk.
Okay, so what are the main types we should know about?
Right, let's break down the main types of anesthesia techniques. First, moderate to deep sedation, often used for procedures outside the OR, maybe reducing a dislocation in the ED. Trained RNs can provide this under physician supervision, and ACP doesn't have to be there, but careful monitoring is always essential. Then monitored anesthesia care, MAC. Used for diagnostic or therapeutic procedures, maybe in or outside the OR, like endoscopy. This involves varying levels of sedation, pain relief, anxiety reduction. The key point. MAC must be provided by an ACP because the patient could get deeper than intended, potentially needing general anesthesia or advanced airway help.
Big difference there.
Huge. Next, general anesthesia. The choice for long, complex surgeries needing muscle relaxation or maybe uncomfortable positions, or for uncooperative patients. The goals: control the body's stress response, protect the patient. Techniques like total intravenous anesthesia, Tavia aim for rapid onset and quick elimination, helping with earlier discharge. General anesthesia has distinct phases. Pre-induction assessment, maybe giving a benzo for anxiety. Induction, making the patient unconscious, securing the airway. Maintenance during the surgery, continuous monitoring, adjusting drugs. And emergence, preparing for wake-up, removing airway devices, assessing pain.
And what kind of drugs are used?
The agents usually include IV induction agents like propofol for rapid sleep onset. That allows quick placement of an LMA laryngeal mask airway or an ET tube and a tracheal tube. Then inhalation agents like desflurane or sevoflurane maintain the anesthesia. Complications, sure. Respiratory irritation from some agents or issues with inserting the airway device. And general anesthesia rarely uses just one drug. Adjuncts are common. Opioids for pain relief. Benzodiazepines for amnesia. Neuromuscular blocking agents, muscle relaxants for better surgical access, antiemetics for nausea. You, as the nurse, might need to reverse some effects. Naloxone, for instance, reverses opioid respiratory depression, but remember, it reverses the pain relief too.
Right, trade-offs.
Then there's dissociative anesthesia, drugs like ketamine. They interrupt brain pathways, create this unique state catatonic appearance. Amnesia, profound pain relief, potent stuff. But it can cause hallucinations, nightmares on emergence, often managed with concurrent midazolam and a quiet PTCU. Lastly, local and regional anesthesia. Loss of sensation without loss of consciousness. Local is topical or injected into a specific spot. Regional or a block targets a central nerve or group of nerves. Advantages: rapid recovery, quick discharge. Good for patients with comorbidities who might not tolerate general anesthesia well. But there are risks: discomfort, infection, and critically, local anesthetic systemic toxicity.
Last.
Tell us about that. Yeah, last is serious. It happens if the local anesthetic accidentally gets absorbed systemically into the bloodstream. It can affect the brain and heart. Early signs can be subtle confusion, metallic taste, numb lips, dizziness, but it can progress rapidly to seizures, dysrhythmias, if not treated fast.
And the treat?
Lipid emulsion infusion is the specific treatment. along with strong respiratory and cardiovascular support. You have to recognize it early. Within regional, spinal versus epidural anesthesia are key techniques. Similar goals, different pathways. Spinal anesthesia injects local anesthetic right into the cerebrospinal fluid, the CSF, in the subarachnoid space, usually below L2. Result, rapid, deep block autonomic, sensory, and motor. Patients often get hypotensive from vasodilation, feel no pain, can't move their lower body. Used often for lower extremity, GI, prostate, GYN surgeries.
Okay.
An epidural block injects into the epidural space outside the duramater. It bathes the nerve roots as they exit the spinal cord, blocks sensory pathways, maybe some motor depending on dose, often used for post-op pain control via catheter or combined with other techniques, common in obstetrics, lower extremity vascular surgery.
So monitoring is key for both.
Absolutely vigilant monitoring for both. Watch for signs of autonomic blockade, hypotension, bradycardia, nausea, vomiting. A too high block is a concern. Tingling arms, breathing problems, even apnea. Other potential issues: post-dural puncture headache, back pain, urinary retention.
That's a fantastic overview of the anesthesia landscape. Now, we know every patient is unique, and sometimes despite all the planning, things can go wrong unexpectedly. What about specific patient groups or those rare but critical crisis events?
Excellent point. It really is about being prepared for the unexpected while managing the expected variations. For genealogic considerations, older adults need really careful titration of anesthetics. Their bodies process drugs differently. Absorption, distribution, metabolism all change. They're also more prone to fluid loss, hyperthermia, skin breakdown from pressure, or even pooling prep solutions because their skin is less elastic, sensation might be decreased. And joint injury from positioning is a risk too, especially with osteoporosis or osteoarthritis.
And post-op delirium.
Yes, post-op delirium is common. So vigilant monitoring and clear, simple communication are essential for their safety. Now, perioperative crisis events. Some can be anticipated, others hit without warning. Anaphylactic reactions, severe allergic reactions, life-threatening, rapid hypotension, tachycardia, bronchospasm, pulmonary edema. What's tricky is anesthesia can mask the early signs, so vigilance and rapid intervention are crucial. Latex allergy is still a big concern, requires specific protocols, a latex-safe environment.
Right.
And then we have malignant hyperthermia, MH. This is one of those really scary ones. It's rare, genetic, life-threatening. Characterized by hyperthermia with severe skeletal muscle rigidity, it's mainly triggered by succinylcholine, especially with volatile inhalation agents, but stress, trauma, even heat can contribute. The basic problem: it's a hypermetabolism of skeletal muscle caused by altered calcium control inside the cells.
What does that lead to?
It leads rapidly to sustained muscle contraction, intense heat production, hyperthermia, low oxygen, hypoxemia, lactic acidosis, and hemodynamic instability. Key signs: tachycardia, tachypnea, hypercarbia, rising end-tidal CO2 is a really important early sign in ventricular dysrhythmias. But a big rise in body temp, that's often not an early sign, which makes it insidious. If you see that rising CO2, rising heart rate, maybe some muscle rigidity even before a fever spikes, you have to suspect MH.
And the nursing management, it must be immediate.
Absolutely immediate. Without prompt detection and treatment, it can lead to cardiac arrest. The definitive treatment is giving dantrolene, dantrium, or Ryanodex immediately. It slows metabolism, reduces muscle contraction, other critical actions. Stop all triggering anesthetic agents immediately. Give 100% oxygen. Actively cool the patient ice packs to groin, axilla, neck, chilled 4D fluids. And monitor closely for complications like hypotassium, DIC, compartment syndrome. Prevention involves a thorough family history and taking precautions for anyone known to be at risk.
Wow, what an incredible journey through this intricate world of intraoperative care. From those meticulous OR zones, the synchronized team roles, all the layers of safety, the signs of anesthesia, it's just crystal clear that vigilance, expertise, and really understanding the nursing process are absolutely paramount.
Absolutely. You can really see how critical the nursing process is, from assessment and advocacy to life-saving interventions and education. Understanding these foundations, especially complex things like anesthesia types and crises like MH, that's what empowers you to give safe, truly patient-centered care. You are that crucial link, ensuring well-being every single step of the way.
So what does this all mean for you, the learner? It means every detail, every protocol, every bit of knowledge we talked about today, it contributes to the difference between a good outcome and a preventable complication. It's about being prepared, being precise, being that patient's most trusted advocate when they're at their most vulnerable. And as you continue your studies, think about this. Surgical tech is constantly evolving: robotics, personalized medicine, How might the core principles of perioperative nursing, especially that patient advocacy and vigilant human oversight, need to adapt or maybe even intensify in a future OR where AI might play a bigger role? What does truly patient-centered care look like when the tools get smarter and smarter? Keep that question in mind as you move forward into your practice.